hello, listeners in the EMS world. Dr. Fayez Azizi, your EMS Medical Director from the Jump Seat. And today I'm speaking with Dr. Seth Duke. He is the clinical professor, faculty at Loma Linda University Medical Center. He's also medical director for American Medical Response in San Bernardino and Riverside counties. We today want to talk about King Airway. Some of you know we've made some changes to our protocol with regards to King Airway. And I know Dr. Dukes has looked at this over the last few months and has been able to put together a little presentation that we're going to share with you to really outline what the basis for our decision making with the recent changes are. I think it's important for everyone who uses our protocol have a working understanding of how we come about making these protocols and what our rationale and decision making is. Seth, welcome. Thank you for being here today.
Thank you so much, Reza. It's a pleasure to be with you, and I hope I can impart some of the stuff that I've read.
Excellent. So why don't we just jump right in, and I'll interrupt you when I have a few questions, but we'll try to get through a few slides you have that highlights the latest data on this. So it's all yours.
All right. Thank you so much, Reza. All right. So as Dr. Fayez Azizi said, we're going to be talking about King Airway specifically in the setting of out-of-hospital cardiac arrest. So to start this off, if you've had the opportunity to come see me lecture in the pre-hospital system, you'll recognize these slides. But here we go. So the first paper I want to talk about was published in Resuscitation. Back in 2014, it was by McMullen et al. And specifically, they were looking at airway management and out-of-hospital cardiac arrest, where they went through the CARES registry to see what patients got and at their outcomes. So the patients received either intratracheal intubation, either got a supraglottic airway, and we'll break those down in a bit, or they got no advanced airway, aka BVM or bag valve mask. There's a little over 10,000 patients they went through. They were all adults. They looked at the 4 outcomes, which were ROSC, made it to admission, made it to discharge, and they made it to discharge with good neural outcome. Here's what they found. So we got the pie chart to the left, gives a breakdown of what everybody got. The blue there is the intratracheal intubation, that's the ETI. 53% of that 10,600 something patients were intubated, 18% got a BVM, 29% got a supraglottic airway. Now, out of those 29%, we get the pie chart to the right to see what supraglottic airway they received. 88% of those supraglottic airways were King, 2% LMA, 10% Combi tube. So here's what they found, and this is kind of really what we want to know the most about. Those who made it to discharge with good neural outcome. To the left there is the ETI, that's the intratracheal intubation, a little over 5% made it with good neural outcome. Supraglottic airway in the middle, about 5% with good neural outcome. But if you look at the BVM group, over 18%, almost 19% of those patients, those 10,600 who got a BVM, made it with good neurological outcome in the end. If you want to really look down at the breakdown of numbers, you can see who got ROSC, who made it to admission, discharge, and good neural outcome. Again, BVM won in every category. Hey,
Seth, what did they define as good neurologic outcome? Was it modified ranking scale, 0, 1, and 2?
Yes. Excellent. I'm pretty sure. You're killing me, Reza. I'm pretty sure.
That's good. No, I just want to make sure. I'm sure that's pretty standard, actually.
Yes. But the answer to your question, that's my understanding, yes, it was a modified ranking score. So you saw their conclusion, BVM did better than everybody. There's a couple arguments against that when you looked at this. One of them was that the BVM group, more of those patients had an EMS witness arrest, and so you break down the data, that is indeed true. 18.6 of the BVM group versus 9.4 of the supraglottic and 10 versus the intratracheal intubation. So we would assume that those that were witnessed by EMS would hopefully have a better outcome. And then also at the very bottom there, one of the other arguments was that there was more shockable rhythms in the BVM group versus the other two. And again, we know having a shockable rhythm, aka VFib or pulseless VTAC, does better than a asystole or a PEA group. And yes, there were a little more shockable rhythms in the BVM group versus the other two. So that is something to keep in the back of your mind when looking at the data. All right, take home message was intratracheal intubation better than King Airway? Not really when you look at the data, and ultimately BVM was the best. So moving on, let's take another look at another study here. This study is specifically by Segal et al. They are measuring carotid artery blood flow when they, the different airways that they put into these pigs. So looking at this line here, that top one is the one I'm going to focus the most on, the pink or purplish color there. And off to the left, you see the CBF is the carotid blood flow. You see there's good high blood flow, and then they induce VFib into the pig, and we see the carotid blood flow drops to pretty much zero, and that's what we would expect. They let the pig go for about 6 minutes, and then they start CPR. You can see there with the arrow, and then it jumps back up, and we start seeing some carotid blood flow. They then, the ET tube, so they intubated the pig, and you can watch the blood flow. They take the endotracheal tube out, they put a combi tube in, and you see that sudden drop off in blood flow to the brain. We see this as a problem. We need blood flow to the brain. We want to save the brain for a good neural outcome. This is obviously an issue. They take the combi tube out, they intubate it, the pig again with an endotracheal tube, and we see the carotid blood flow jump back up. They take it out, they put an LMA in, we see a drop, but then the LMA starts to rise again. They take the LMA out, they put the endotracheal tube in, they take the endotracheal tube out, and they put in the King airway. And we see that drop again. Not as bad as the combi tube, but we see a sudden drop. They take the King tube out, and they put the endotracheal tube back in. It comes up a little bit. And we do see a steady decline in the carotid blood flow, and that would unfortunately be expected as cardiac arrest continues over time. We are going to see a steady decline. Now, the bottom graph there is looking at the airway pressure, and we can see that all these different adjuncts or different, be it the combi tube, LMA, King airway, endotracheal tube, they all are able to ventilate. In other words, we're getting pressure down there, but when we're looking at trying to have a good neurological outcome, we need that carotid blood flow, and we're seeing that some devices sacrifice that carotid blood flow, unfortunately.
Yeah, I think I'm glad you pointed that out, because that mission is accomplished with regards to the airway pressure is really not dependent on the device used, but clearly the devices showed significantly different profile when it comes to the carotid blood flow. And I think that's a very good point to kind of focus on.
Thank you. Yeah, and so keep this in back of your minds. We talk more about endotracheal tube and that King airway, that drop that happened when you put the King airway in. Now, the latest study that kind of made some waves in this topic would be the Wang et al. Study, where they looked at laryngeal tube insertion versus endotracheal intubation in out-of-hospital cardiac arrest. And specifically, the laryngeal tube insertion, as I understand, was the King airway. It was a randomized trial, 27 different agencies that are part of the ROC group, adults, non-traumatic, 2015 and 2017. One interesting thing is they did not limit the number of attempts to try to get this person to either have a King airway or endotracheally intubated. Another thing is, if you were that once you went for the initial attempt, if it didn't work, you could do whatever you wanted after that. So if you're supposed to get intubated and it didn't work, you could put a King in and vice versa, or just BVM. This was some interesting numbers. The initial King airway success rate was 90.3%. However, the initial endotracheal intubation success rate was 51.6%. Not very good, unfortunately. Looking at those numbers, you can already probably make a guess of how the patients are going to do. Again, so here's what the published numbers, and we're looking at the intent to treat group. The King airway, 18.3% made it to 72-hour survival. Endotracheal group, 15.4% made it to 72-hour survival. You can look at the ROS rates. We're a little bit higher in the King airway group. So was survival to hospital discharge, and so was favorable neurological outcome. So the conclusion that you see at the top of the paper is that initial King insertion had a higher survival rate at 72 hours compared to the endotracheal intubation. So when I read this and I see something that makes me pause for a second, I like to dig a little bit further in the study. And we're going to go through this pretty quick to not to belabor the numbers, but we're going to break up each group. Here's the King airway group. Again, this was, if you were assigned, this was intent to treat. So if you were assigned King and you got intubated, you still fall under the King group. This is breaking down all the different numbers. You see the red boxes. The success rates of intubation were not good. Here's the intubation group. You can see the success rates of the intubation was not good. And the bottom box there with the red little box around it, out of those that failed intratracheal intubation, a significant number still got a King airway. So within the endotracheal group, several still got a King airway. So this brings us to the as treated analysis. So the first part where you see in the study is the intent to treat, but let's look at the as treated, so what the patient actually got in the end. If you look at the as treated analysis, there was no significant difference in 72-hour survival between the King airway, between initial King and initial endotracheal intubation. If you dig a little bit further in the data, this was the most interesting part of the study, I thought. Look at the BVM group. So initial airway attempt, if you initially had a BVM instead of anything else, you had 32% survival to 72 hours as compared to 13.5 in intubation and 16 in King. If your final airway attempt was BVM, you still did better at 26% compared to 15.2 for King and 13.8 for endotracheal intubation.
This is really fascinating, Dr. Dukes, because it isn't necessarily a natural conclusion that advanced airways aren't going to help you, but clearly here, less is more with regards to the out-of-hospital cardiac arrest. So I really think that probably is the most important take-home message here.
And it was huge, and I wish I had been more prominent in the data, but if you really dig it, it's in there, and it's not subtle. So the take-home message, intratracheal King airway, this study showed that there's no significant difference if you looked at the as treated, but if you looked at the as treated, BVM killed them both, not even close. All right, so next study I want to talk about was a study out of Japan. And studies out of Japan are great because they have so many numbers to look at. It was a prospective study, adults, resuscitation by EMS, and nothing was randomly assigned. They just took a look at what they got and how the patient did. And ultimately, since they look at what they got, EMS chose what to do. It's from 2005 to 2010. And their numbers. So in that 5-year period, they had 658,000, almost 659,000 adult cardiac arrests. They broke them down. Out of those, BVM group, 367,000, whereas in advanced airway, about 42,000 was endotracheal intubation, about 240,000 was a supraglottic airway. So how'd they do? BVM group, ROSC, 7%, ROS for the endotracheal intubation, 8.4, and ROS for the supraglottic airway, 5.3. So ROSC did a little bit better in the intubation group. If you look at 1 month survival, BVM 5.3%, intubated 4.2, supraglottic airway 3.8. So BVM's winning with intubation following behind. And favorable neurological outcome, BVM 2.9%, intubated 1%, supraglottic airway 1.1%. BVM wins again. And that's what they found. Any type of advanced airway, the patient did worse. All right. So you get to this point and you're like, okay, things don't look good for anybody except for BVM. And then this study hit just at the end of last year into the JAMA. This is there was a randomized controlled trial looking at BVM versus intubation in the France-Belgium area. Again, randomized BVM intubation, a little over 2,000 patients, 2015 to 2017. And the reason I enjoy EMS out of France and Belgium is this. They're doing some pretty interesting things, including ECMO in the field, in the pre-hospital setting. I had the opportunity during my fellowship to spend some time in Australia, where there were also physicians from the pre-hospital system from France and Belgium area. And some of the stuff they're doing over there, it's cool. It's impressive, the resources they can bring to the pre-hospital setting. Anyways, pipe dreams. Maybe one day, huh, Reza? One day?
Okay, well, let's just stay to the basics for now.
All right. So how the patients do. So if you look at their BVM and their intubation group, survival to 28 days was equal in both. 5.4 in the BVM, 5.3 in the endotracheal group. If you look at the good neurological outcome, also very similar. Their ROS group was a little bit higher in the intubation versus BVM, but we saw that in prior studies. And that it's, ROS versus good neuro outcome versus survival. If you look at survival and good neuro outcome, it's similar. So what they find, that there's really no significant difference between BVM and intubation. Now, one of the difference here is, if you remember the Wang study, their intubation success rate, first pass success rate, or initial success, was 51%. In this study, they don't spell out what their first pass or initial success was, but they do state that there was a little over 13% of difficult airway group. And based on reading through the lines, it appears those would be the ones that didn't pass on first success. So we can make a semi-judgment call that the first pass was somewhere around 86%, which is better. It's not great, but it's much better than 51%. They also state that their intubation failure rate was only 2.1%. So those who were supposed to get intubated ended up getting intubated, and so on. And that's what I've got for this short discussion on King airway versus BVM versus intratracheal intubation and King airway and out-of-hospital cardiac arrest.
So, Dr. Dukes, looking at all what you just talked about and being also a physician that clinically practices, what does all this mean to you next time you're going to have an adult cardiac arrest patient in the emergency department? How has this changed the way you will practice resuscitation on that patient?
All right, I agree. This is where the rubber meets the road. So I can speak personally for my practice. Just yesterday, I was working in the ER, and we had a cardiac arrest patient come in. And based off of all this data and research that I've been through, is we perform BVM. Now, this was an adult out-of-hospital cardiac arrest. And the reason they were transported is they got ROSC initially on scene. They lost pulses again just prior to arrival, so they showed up performing CPR. We continued with BVM. The crew had only had BVM since they had attained ROSC. And we did not intubate until after we had ROSC in the patient. And is that really what's beneficial? In my mind, after looking at the data, it's hard for me to say that it's not. So that's how I personally practice is BVM, BVM, BVM until I can get ROSC. And then if they're not breathing on their own, there's other issues, then we can worry about intubating.
And I agree. And I think that kind of lines up with everything else we know about out-of-hospital cardiac arrest resuscitation, which is the impact of uninterrupted, high-quality CPR and not allowing anything else to disrupt that. And often airways not showing any significant improvement over BVM or BLS airways become the source of that interruption. So we're actually not doing a favor to our patients by insisting on advanced procedures in that setting. And I think that really is the major take-home message. Hey, listen, I want to thank you for joining us today and presenting your discussion on this. It was very nicely done. I'm really grateful. Hopefully this is useful for those of you that are watching and listening to this. This is Dr. V from the Jump Seat, and look for future episodes of From the Jump Seats on other EMS related topics. Thank you very much.
All right, thank you, Reza. Take care, sir.